Hello and welcome again. It have been long. After 3-4 days, I'm taking class because of some problems at Unacademy itself. So basically, I'd like to welcome you at a NEET PG exam preparation. So here we are just for NEET PG exam, and here will be our main logo is Let's Crack NEET PG. So you are at an Unacademy platform, and I myself I am Dr. Anil Sharma. Basically, I am Dr. Anil Sharma, MD pathologist. So basically, I am Anil Sharma, and I am MD pathologist. I am MD pathology from AIMS. Okay, so we have been together for around 2-3 classes now. In here, we have been doing renal. So we have completed glomerulonephritis. Now we will be starting tubular injuries from today's class. Basically, we'll go slowly and learn about the basic information. Before that, I'd just like to say you all that please come be our family, join us as a family, and as a family we'll try to crack it. Okay, together we'll try to make our logo successful, that let's crack NEET PG. Okay, so for joining into this or being a part of our family, what you need to do is you just need to download Unacademy learning app. So you can install that Unacademy learning app, and then you can just get subscription. So with subscription you can get a plus subscription and iconic subscription. So what the plus subscription will do, so plus subscription will help you to get the live classes, like this is a live classes. Similarly, different other teachers takes live classes. Okay, other faculty also take live classes, even for pathology and other all 19 subjects. Then you have live test and quiz. You have batch courses, you have structured schedules. Okay, we have a schedule which is very much structured and well planned schedule. So these are the main characteristics of plus subscription. Okay, so you can just, for me, this live classes is gold, and obviously live test and quizzes are gold thing. Basically, you will get test series, you can join test series. Then in iconic you have a very good surprise element, that is you will be getting prep letter also. Now this prep letter, as we all know, it's a very wonderful app for preparation of PG exams, because it have video lectures from one of the best faculties in India. Okay, then you have question bank which they have prepared. I myself have my content is also over there. I had given my content over there also. For the question bank, we had collected questions so accordingly here, and we had divided them according to the subject, each topic. Okay, and in that topic the division of question are done, and the questions are done set that way, or they are arranged in such way that you will understand that topic matter clearly. So आपको पूरा complete topic matter clearly समझा दिया जाता है. So there is again rapid revision courses and handwritten notes. Okay, then obviously these all the features of plus Unacademy you will get. So just you can get the subscription of plus or either iconic. So with iconic you are getting prep letter also. So now coming to the price list. So for 12 months you are paying 55,000. That with 10% discount by the promo code ANLIV you get 49,500. Okay, that is around 5,500 rupees profit or saving you are doing. Now coming to the plus subscription. So for plus subscription, for 12 months you are paying 27,500. After application of Anil Live, for 12 months you are paying 24,750 rupees. Again you are getting a discount. So in each every subscription you will be getting some what of discount. Okay, some amount of discount. So that is very important thing. So your labor, your hard work, basically that is very necessary. And again your hard work with our materials and obviously our support with together will help you to crack the NEET PG exam. And again there the support which you will get from the teachers like Dr. Jainab Bora. She is a gold medalist in radiologist, and I assure you that if you listen her lecture, if you listen her motivation speeches, basically you don't require any other lectures in radiology basically. Then you have Dr. Preeti Sharma. Obviously everybody know about her in pathology. She is just she have ocean of knowledge. Okay, so basically her topics, or whatever she have covered, basically either it might be of stain or image basis, maximally those some questions from there are sure to come. Then you have Dr. Pawan Kandhari, surgeon. So he is also one wonderful teacher, which basically who covers you in an integrated way. So all these teachers are basically more or less approaching will help you to approach integrated way, and that is the best way to study. Integrate your studies, okay? Integrate the things. So that is your best approach. So now we today will start with our tubular and interstitial diseases. So we just talk about the glomerulus. So we had done about in the renal section what we did about glomerulus, we did about glomerulonephritis, different type of glomerulonephritis, okay? So we did about this part of glomerulus, but now below this glomerulus there is duct, okay? So there is duct. So we need to talk about this duct also. We need to talk about this duct. Basically we need to talk about PCT, DCT and all. We need to talk about this duct very importantly. Sorry. So basically this today we'll talk about, will more give our more emphasis on this tubular injury, okay? So basically what we call is acute tubular injury or acute tubular necrosis. So previously it was called as acute tubular necrosis, but in the present scenario we don't call it necrosis, because it's not necessary that always there is necrosis is present, okay? So basically these tubular or interstitial diseases are, again we have seen the images of kidney where there would be glomeruli. So suppose this is a glomeruli, okay? Here you would be all this capillary, okay? Here it will be all this capillary. So this is a glomeruli. Then obviously here we have talked about proximal tubules and distal DCT and proximal tubule. So what we talked about DCT and proximal tubule, I said that PCT, that is proximal convoluting tubule, will have more eosinophilic cytoplasm, and there will be brush borders over here, okay? There will be brush borders over here, there will be brush border, and in DCT there will be less eosinophilic and no brush borders, okay? And there will be no brush borders. So I just explain. So between these two there will be a space, there is a space, okay? There is a space. This space is basically known as interstitial space, okay? This space is known as interstitial space. So today now we will talk about these tubular diseases. So diseases which are associated with these tubules, and also diseases which are associated with the space between these tubules, that is interstitium. Now one thing you should know very well, any disease whichever we did previously, also glomerulonephritis, most of the disease they will involve the interstitium and tubules, okay? But we focus more on glomerular diseases will focus more on glomerular, and here the tubular disease will focus more on the tubules, okay? So what are the different diseases which, or what are the classification, etiology which will cause this disease, okay? So basically when we start any type of disease, we start from genetics, okay? So we'll talk like what all comes in your mind. You just go towards genetics, you'll go towards infections, okay? Different infections, and you'll go towards autoimmune causes. If there are any किसी भी disease का आप etiology बोल रहे हो, तो आपको just you think sequentially. When you think sequentially, like genetic factors, okay, you will think about genetic factors, you will think about infections, you will think about some of the autoimmune disorders, autoimmune things, okay, immunological things, whether it is caused by some immunological things or not. Then obviously you will cause about some toxins or all, which are toxins or all which are causing the disease or not. So these are some, and then you will just think about that there is any endocrinological factors or not, okay, endocrinological factors or not, metabolic factors or not. So in each and every disease when you talk about etiology, you just need to think about कि हाँ इसमें कुछ metabolic factor हो सकता है, इसमें कुछ endocrinological factors हो सकता है, ये thyroid की वजह से कुछ हो सकता है, autoimmune SLE इधर vasculitis इनकी वजह से कुछ हो सकता है क्या? So you should just think about that, and when you think, when your thinking process, when your mind is clear and when your thinking process is clean, obviously you can answer the question very easily, okay? So etiology when we talk about, so in genetics what we have, in genetics you have different types of gene, like clyopathies. Example, in clyopathies you have nephrotoxic group, okay? Then you have autosomal dominant tubulointerstitial kidney diseases which are normally associated with the genes MOC1, SNF1 beta, UMOD, and you have mitochondriopathies, and you have adenine phosphoribosyltransferase transferase deficiencies, okay? Infections, there can be direct infections like polyoma virus, acute pyelonephritis, tuberculosis, brucellosis, or there can be indirect infections, okay, different gram positive bacteria or gram negative bacteria, okay, so they can be causes. And then you can have, as I said, see, there will be immunological, okay, immunological causes which you can have. This is nephrotoxic also, which can be because of exogenous antigens or can be autoantigens, alloantigens, basically like autoantigens. Again we talked about Sjogren syndrome, tubular basement membrane disease, anti-cross border antibody disease, unknown etiology like sarcoidosis, Ig4 systemic disease, tubulointerstitial nephritis with uveitis, or idiopathic hypocomplementing nephritic syndrome. So we'll talk about all these diseases, okay. So different antigens, they can be different, or they can be associated with toxins like lithium associated nephropathy, calcineurin, different drugs, okay. We'll talk about this chemotherapy, different drugs, okay. We'll talk about this aristocolic acid nephropathy also, or Balkan nephropathy भी कहते हैं इसको, okay. When different herbs, different spices, different heavy metal poisoning, so these all the toxins, they can also cause tubular injury. Or then, as I said, there can be any metabolic causes are associated or not, like bile cast nephropathy, oxalic acid, that is oxalosis, secondary oxalosis, gout nephropathy, acute phosphate nephropathy, or nephrocalcinosis. So this, there are metabolic causes or not in etiology. Then obviously for acute injury, there are basically other ischemic causes like acute tubular injuries, rhabdomyolysis. Then basically there can be post-renal causes like obstructions and all. Radiations can cause diseases, neoplasia like myeloma cast nephropathy, light chain tubulopathy, and idiopathic like Behçet's disease or cardiomegalich intestinal nephritis. So these are some of the important causes of नेफ्राइटिस. बस दिस स्लाइड आपको सिर्फ इतना कहने का कि आप कभी भी कोई भी ईटियोलॉजी देखते हो तो सिक्वेंसली सोचो उनके बारे में, कहीं भी किसी भी ऑर्गन का डिजीज हो, नॉट ओनली किडनी, ओके. सो नाउ सी, first you should know something basic when you go towards tubules. So you should know something basic about the tubular injuries. You should know something about basic about the tubule and their function, okay. So normal kidney functions, they occur through numerous cellular process. So basically you need, whenever normal kidney function, it is occurring because with the help of numerous cellular processes, okay. There are a lot of feedback mechanisms, there are a lot of mechanisms, there are a lot of molecules or hormones or enzymes which are helping in maintenance of the flow, renal blood flow or renal plasma flow, okay, and glomerulus filtration. So if there is problem with any of these steps, okay, then you are going to see the renal injury. So disturbance in any function will result into the abnormalities, okay. So what are the nephrological syndromes which you can see in case of renal disease or tubular interstitial disease? So you can see GFR, reduction in GFR. You can see abnormalities of urine sedimentation. So this is an overview, okay. So whenever you talk about renal diseases, what you need to know, you need to measure GFR. So this will be an investigation also. You need to know how to calculate GFR, okay, glomerulus filtration rate कैसे calculate करते हैं. You need to know about how to see the urine sediment, how to see different types of how to microscopically how to do routine urine examination, and you need to know what all you need to see, different type of cast, okay, different types of cast and different types of cells which you need to see in crystals, you need to see in case of urine sedimentation, okay. So here you need to know red blood cell cast or WBC cells or cast and crystals. So what all you need to see. Then you have basically you see about the proteins, you check about the protein whether it is associated with proteinuria or not, whether it is associated with hematuria or not, and obviously this glomerulus filtration rate obviously associated with the urine output, okay. Then obviously disturbance of the urine volume like oliguria, anuria or polyuria. Then obviously associated symptoms associated with renal failure like hypertension or expanded fluid volumes, edema. Then obviously you will see any electrolyte abnormalities, any anion gap is present or not there, which type of anion gap is present, okay. Then which will lead to the metabolic acidosis. So basically this tubular injury will is a broad topic. You need to know different things. You need to know about electrolytes, you need to know about anion gaps, okay. You need to know about respiratory acidosis, metabolic acidosis, more or less you need to know about metabolic acidosis and alkalosis, okay. That is very, very important, and those so integrate all those things together. When you integrate all those things together, basically your a big topic is completed. Okay, आपका बहुत बड़ा topic complete हो जाता है. So that is very 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 important when you do when you read about tubular injuries. Okay, so the first thing is you just read your physiology. You need to go and read your physiology. Just आप अपना physiology को एक बार देखो, glomerular GFR and all, how you calculate GFR and all, that is very very important. So let's first see the symptoms azotemia. Okay, so the first thing which we come forward is azotemia. So for azotemia, what you do, you need to do assessment of GFR. So what is GFR? Is basically primary metric for kidney function. Okay, so this now GFR, how do you measure GFR? So GFR basically you can measure by administration of inulin or iothalamate. Okay, iothalamate. So inulin, which was previously used, nowadays it is iothalates are used, but basically this both are very tedious to do and very difficult to do. So clinically mostly they are not done. Okay, clinically they are mostly not done, but yeah, for theory portion, for theory purpose, so these are the best agents which can be used to measure GFR. This can be used to measure GFR, because now why they are important? Why they are important? Because they are filtered. Okay, at the glomerulus they are filtered. So we have talked about, obviously when you give inulin or iothalamate, what happens? They will filtered at the glomerulus into the urinary space, but they will neither be reabsorbed nor be secreted throughout the tubules. Okay, so they will be filtered and they completely, जैसे डाला ब्लड में वैसे वो ब्लड से फिल्टर हो जाएगा ग्लोमेरुलस में, और ट्यूब होते हुए वो फिर यूरिन में निकल जाएगा. ठीक है, सो कम्प्लीटली यूरिन में निकल जाएगा. सो जस्ट वी मेजर the amount which was given and the amount which is filtering. Okay, so basically this is neither reabsorbed neither secreted throughout the tubules, hence GFR, so glomerular filtration rate, can be easily measured by this thing. Okay, glomerular filtration rate can be easily measured by this thing. Now what do you need to know? Another is basically clearance of inulin or isothalamate in millimeters. So how do you measure? You measure basically in milliliter per minute. Okay, per minute, milliliter per minute. Okay, so you just measure milliliter per minute. So normally GFR, the normal GFR is around 120 milliliter per minute. Now see, आपको किडनी का फंक्शन कितना अच्छा लगेगा कि there is a GFR of 120 ml per minute. हर मिनट में 120 ml फिल्टर करता है, ये ब्लड से 120 ml फिल्टर करेगा हर एक मिनट में. ओके, हर एक मिनट में 120 मिनट. सो अराउंड इन होल डे इट विल मेक अराउंड 180 लीटर्स ऑफ यूरिन. 180 लीटर्स ऑफ यूरिन. नाउ सोचो अगर 180 लीटर्स कंप्लीटली यूरिन आपके बॉडी से डेली पास होता तो कितना होता? 180 लीटर. So now remember, you will urine out around 1.5 to 2 liters per day. आप completely 1.5 से 2 लीटर प्रतिदिन का यूरिन आउटपुट आपका है. So now where the hell this 178 liter goes? So 178 liter को वो फिर से renal tubules and all they absorb back. Okay, so they are absorbed back. So remember, so how sophisticated the function is? How sophisticated the function is that it is absorbed back. Okay, it is absorbed back. So basically you require a very sophisticated phenomenon, and kidney have a very very sophisticated phenomenon. Okay, and remember clinically you cannot measure GFR. You cannot measure GFR using basically inulin. So what you do is you just measure plasma creatinine level. So plasma creatinine level, basically it is used as a surrogate marker for GFR. Okay, so plasma creatinine level is a surrogated marker, and basically remember plasma creatinine, it is the most widely used marker for GFR. For GFR, plasma creatinine is the most common marker which is used in case of GFR. Okay, that you need to know. So GFR, basically GFR you measure from renal plasma flow. So what is renal plasma flow? So there is renal plasma flow or renal blood flow. So this renal plasma flow is normally there is around, you know very well, there is around 20% of your cardiac output, 20% of your cardiac output is basically going to renal. Okay, so this is going to renal. So renal plasma flow or renal blood flow is around 600 to around 600 to 700 ml, 720 ml per minute. Okay, this much flow you will get, and in that, remember, 120 ml per minute is basically filtered. Okay, ml per minute is basically filtered. That is, you need to know that thing, you need to know. Okay, so that is very, very important. Then again we have talked about filtration in glomeruli. Okay, filtration in glomeruli we have talked about again and again, that in glomeruli obviously this is अगर ये आपका basement membrane है, we have said about that there in the basement membrane what will be there, this will be lamina densa, this will be rara, lamina rara, this will be lamina interna, this will be lamina interna, and this is lamina densa. Okay, so here this side you will have podocyte, okay, and this side you will have endothelium fenestration. Okay, this side you have endothelial fenestration. So these are the endothelial fenestration, and these are the filtration slits. Okay, these are the endothelial fenestration and filtration. So this is around 70 nanometer of size, and the size of this food process and this filtration slit is basically 20. So this gradient which you can see in place of the two members, outer and inner membrane. So outer and inner membrane, so this gradient help in filtration, this gradient help in filtration in case of glomerular filtration. Okay, so this is again a very much important topic. Then now what you have, another thing is plasma creatinine is most widely used marker for GFR, related directly to the urine creatinine excretion and inversely to the plasma creatinine. So GFR is basically, remember, it is directly related to urine creatinine excretion, so urine creatinine excretion, and inversely to the plasma creatinine. That you need to remember in your you need to keep it in your mind. Okay, significantly whenever there is reduced GFR, when GFR is reduced, that means you are going towards kidney injury. Okay, so basically when GFR is reduced, when the glomerulus filtration कम हो रहा है, इसका मतलब क्या हो गया कि आपका जो वेस्ट मटेरियल है, the waste material ज़्यादा रिटेन कर रहा है, ठीक है, रिटेन कर रहा है, and that retention of waste material is basically known as azotemia. That is known as azotemia. So basically like urea is basically retained in more amount. Okay, so because why this occurs, because of reduced renal perfusion, there is some renal disease, intrinsic renal diseases, or there are post renal processes which we will talk in subsequent topic now. Okay, so what is this creatinine clearance? Okay, creatinine clearance, so you cannot measure GFR actually by inulin, or it's very tedious process. So what you do, you measure creatinine clearance. So creatinine clearance is basically an approximation of GFR. So now why this creatinine clearance is important, because in your exam you will be getting question. Okay, you will be getting questions regarding creatinine clearance. Okay, आपको creatinine clearance का question दे दिया जाएगा, आपको GFR measure करने के लिए बोल दिया. Okay, so measure GFR, where you will be given the value of plasma creatinine, you will be given value of urine creatinine. Okay, and you will be given value of complete urine. Okay, so basically creatinine clearance is basically your urine volume into urine creatinine divided by plasma creatinine into time. Okay, in minutes. So that is again important. This is a very important formula which you need to know regarding creatinine clearance. Now this is the basic formula. Okay, basic formula. Total urine में कितना क्रिएटिनिन है. ओके, टोटल यूरिन में कितना क्रिएटिनिन है और प्लाज्मा में कितना क्रिएटिनिन है, उस टाइम में कितना निकला है बाय रेशियो. तो ये रेशियो जो है ये बेसिकली आपको देगा क्रिएटिनिन क्लियरेंस. बट क्रिएटिनिन क्लियरेंस का स्पेसिफिक फॉर्मूला भी है. इट इज नोन एज Cockcroft-Gault. सो यू कैन बी आस्क्ड रिगार्डिंग दिस Cockcroft-Gault formula. So in this formula you just need, they will just provide you plasma creatinine value. ठीक है. So what they will do, a 60-year male, suppose they will say a 60-year female, अगर आपको कह दिया suppose a 60-year female है ना, weighing जैसे 55 kg, a 60-year female weighing 55 kg है ना, had plasma creatinine of 2.8. So what will be the GFR of that patient? The GFR of that patient will be, so they will just say GFR will be 2.8, GFR will be 4.8. So they will just say and give you option like this. Okay, so hence you should remember this formula. 140 minus age, okay, minus age in years, like 140 and age is 60 years. So ये कितना हो गया आपका 140 and 60 years का कितना वैल्यू हो जाता है. So that is important. So 140 into minus 60, ये आपका जैसे सपोज 80 हो जाता है. 80 आप इंटू वेट इंटू केजी करते हो, ओके, इंटू केजी करते हो, इस चीज़ को फिर 0.85 से मल्टीप्लाई कर देते हो इफ़ इट इज़ फीमेल, ओके, इफ़ इट इज़ फीमेल you do that thing, then just you divide 72 with your 2.8, so आपका creatinine level है, ठीक है. So now this is importantly you need to know about creatinine clearance, okay, this formula, and now you will get the answer if you solve this, okay. So आपको ऐसे क्वेश्चन ज़रूर पूछेगा कॉकक्रॉट ग्लाउड फार्मूला यूज करके. So you need to calculate creatinine clearance by measuring this or by applying this formula. So this is more commonly used formula in case of creatinine clearance, okay. In case of creatinine clearance, this is more important formula. Then also there is another formula also, or another method also, that is modification of diet in renal disease, okay. So another way of measuring creatinine clearance is modification of diet in renal diseases. So this modification of diet in renal diseases is what you said is, that is ml per minute per 173 per meter square. So area भी आपको use कर लिया गया है. So this formula is a bit tough, so you are not going, I don't think that in exam any numerical question regarding this MDRD will be asked, okay. But what you need to know is it uses basically 4 variable, altogether 6 variables, okay, altogether 6 variable, okay. But at present it MDRT, so the modified one, they are using 4 variables. So what are the variables? That is important. So it is a serum creatinine, age, ethnicity and gender, okay. So this is using this 4 variable. Previously there was also BUN was used, BUN BUN, blood urea nitrogen, and albumin level was also used, but now it is not used, okay. Now it is not used. So there are 4 variables which are used in case of MDRD. So you need to know this 4 variable. One is serum creatinine, one is age, one is ethnicity, and one is gender. So this is again an important aspect which you need to know about this MDRD, okay. So you can better just go see your physiology also. Physiology को integrate करना बहुत important है. दूसरा एक और फार्मूला होता है CKD EPI formula, okay. So CKD EPI formula, this was developed by Levy et al, okay, Levy et al, and this is more accurate than now. What important thing you need to know about CKD EPI formula is nothing. The important thing you need to know this is that it is more accurate than MDRD formula, okay, MDRD formula. And in the case also MDRD formula, and especially MDRD formula you cannot apply. So this MDRD formula, this basically modification of diet in renal disease, this formula is mostly applicable when your GFR is less than 60, okay. When your GFR is less than 60 ml per minute per 173 meter square, then you can apply that MDRD formula. If that is greater than 60, then you can apply CKD EPI formula, okay. This is again important. So yeah, this line is important, that a person if having a GFR is more than 60 ml per minute per 1.73 meter square, then for calculation of creatinine clearance, most important formula becomes CKD EPI formula, okay. So now this is a table from your Harrison's, I feel. So now what is this? You are, suppose when you evaluate azotemia, so you diagnosed someone as azotemia. So what you need to do is, where you are suspecting azotemia, what you need to do is you need to do urinalysis and renal ultrasound, okay. So in urinalysis and renal ultrasound, what you need to do is basically you will see renal size parenchyma. So in case of renal ultrasound, you will see renal size parenchyma, or ultrasound you can also see hydronephrosis, okay. So for hydronephrosis, what happen, if the renal cell parenchyma is high, then obviously there is hydronephrosis. But if suppose there is hydronephrosis is absent, so whenever the hydronephrosis is absent, what you do, you do renal size parenchyma and you do urinalysis. But if hydronephrosis is present, then how will the kidney enlarge? When will the kidney enlarge? So it's a very simple logic. So इस चीज को बढ़ने के लिए यहाँ पे कुछ obstruction होना जरूरी है. So whenever there will be obstruction, there will be reflux back, things will reflux backside, and obviously this will try to increase its size so that it can accumulate the newer thing also and the older urine also, okay. So that is the basic formula. So there will be urological evaluation you need to do in case of if hydronephrosis is present, okay. So but now you do renal size parenchyma and you see urinalysis. So we see small kidneys in case of tubular injuries, thin cortex, bland sentiments, and isothnuria. Basically your proteinuria, dipstick proteinuria will be less than 3.5 gram protein for 24 hours. Okay, so in case of azotemia, your urine protein is basically less. Okay, not it is of not never or mostly it is not equal to nephrotic syndrome urine. Okay, so the kidney size can be of small and normal. If it is small, then you see basically you just see the urine analysis and you see that is protein present or not. Okay, and if the kidney size is normal and intact proteinuria, okay, if the kidney size is normal and the parenchyma is very much intact, okay, then what you say, there are chances that there can be acute renal failure. Okay, so what you do in this case, you do urinalysis, and what you see, if there is normal urinalysis with oliguria, then you do urine electrolytes. Okay, you do urine electrolytes, and by urine electrolytes you will know that whether it is prerenal azotemia or renal azotemia. Okay, prerenal azotemia or renal azotemia, you can decide because of this urine electrolyte. How? So basically FENA, that is fractional excretion of sodium, basically they are less than 1%. Okay, FENA is less than 1% in case of prerenal azotemia, but in case of renal azotemia FENA is more than 1%. Okay, this you need to remember. Okay, so and hence your, if FENA is greater than 1, it is acute tubular necrosis. If FENA is less than 1, it is prerenal azotemia. Okay, it is prerenal azotemia, which will be caused by prerenal conditions like cardiac failure, okay, some drugs and all, sepsis, vasoconstriction, and renal vasoconstriction, impaired autoregulation. This all will cause this type of disease, FENA. Okay, then coming to the another, if there are urine analysis is abnormal, so where if the bacteria are present, is pyelonephritis. If WBC cast or eosinophils are present, it is interstitial nephritis. If RBC cast are present, then it is renal artery or vein occlusion. And if RBC cast or proteinuria are present, you need to do renal biopsy, so rule out glomerulonephritis or vasculitis. Okay, so this is the way you approach in case of azotemia. So now it is very easy to define, or basically investigation decide karna becomes very easy after this table. Okay, so basically we talk about prerenal azotemia. So this prerenal azotemia is normally what? It's the most common form of acute kidney injury, and it is basically associated with rise in serum creatinine or burn concentration. Okay, so due to inadequate renal plasma flow and intraglobular hydrostatic pressure to support normal glomerular filtration. So we know very well that for anything that should be, so suppose this is a renal flow. So what you need to know is basically the renal blood flow or renal plasma flow. Okay, so there will be renal blood flow, and this is glomerular filtration rate. Okay, so there are a lot of absorption taking place and secretions taking place in between this tube. Okay, tube opening, there are a lot of absorption and secretions are taking place in this case. Okay, and there are a lot of feedback mechanisms are taking place. There are a lot of feedback mechanisms which are taking place, like myogenic response or basically tubuloglomerular feedback. So this all feedback and different mechanism, they all are responsible for maintaining proper flow of the blood into the kidney. Proper flow of the blood into the kidney is maintained by these mechanisms. Okay, you need to know that. So prerenal azotemia, what you need to know, it is the most common conditions associated with prerenal azotemia are hypovolemia. So now you know very well hypovolemia, it can cause a prerenal azotemia, decreased cardiac output. So basically prerenal, they are before renal. So before renal कौन सा चीज affect कर सकता है, ठीक है? So कौन सा चीज affect कर सकता है? बेसिकली जो चीज़ बिफोर रीनल क्या, वो आपको रीनल में अच्छा ब्लड सप्लाई नहीं कर रहे, वही चीज़ अफेक्ट कर सकती है. सो हाउ दैट विल बी अफेक्ट इफ योर volume of the blood is less, so hypovolemia. If your cardiac output is not good, so whenever there is cardiac output is not good, that means there is problem with cardiac problems. Okay, there are problems with cardiac, or when you are taking some drugs on which are not letting the blood to reach to the kidney. Okay, so these are basically very important understanding which you need to know in case of azotemia. Okay, so now remember, this involves no parenchymal damage to the kidney, prerenal azotemia, and rapidly reversible once parenchymal blood flow and interglomerular hemodynamics are restored. So basically this prerenal azotemia is a reversible process. Okay, reversible process. Now GFR, it is maintained in part by renal blood flow and relatively resistance to the afferent and efferent renal arterioles. So this basically determines the glomerular flow rate and the transcapillary hydraulic pressure gradient that drive glomerular ultrafiltration. Now what we know to understand is, we need to understand that obviously for any substance to move in or out of the capillaries, okay, in or out of the capillary, what they need to know, they need to, and that would be, they need to fight with the oncotic pressure. So they need to fight with the oncotic pressure, and also they need to fight with the hydrostatic pressure. So basically they need to fight with the oncotic pressure and they need to fight with the hydrostatic pressures, okay, the hydrostatic pressure. So for any for kidney, the J flow will be the J flow will matter on these two things, that is oncotic pressure and basically your hydrostatic pressure, okay, that will matter into this will matter in, so basically hydrostatic pressure will be PC minus PI. So PC basically it is associated with Bowman's capsule, and PI basically which it is associated with their kidney, okay, PI is basically associated with their kidney. So PC minus PI minus alpha, that is gamma C minus gamma I. So this is basically, see, this gamma is basically your, what you call it, oncotic pressure, okay, this gamma is your oncotic pressure. So that you need to remember in case of renal blood flow. Now another important thing which you need to remember about renal blood flow is renal blood flow and renal plasma flow. These are actually two different things, okay. So renal plasma flow, basically it is calculated as, renal plasma flow is calculated as renal blood flow into 1 minus HCT, okay. So 1 minus HCT, so this will give you the renal blood flow, renal plasma flow, and actually renal plasma flow is that correct representation of this renal blood flow which we say normally in normal daily life, okay, that is important. So you need to remember this thing. Now this was about renal blood flow and renal. So renal plasma flow, approximately we have discussed that there are approximately 600 to 720 ml per minute. So there is renal plasma flow. So within the plasma, organic and inorganic solutes are present. So basically implies that they can be found in ultrafiltrate, the fluid in the Bowman's capsule and plasma at the same concentration. GFR is approximately 120 ml per minute. Average urine output on the other hand is 1.5 liter per daily. The reabsorption of 178 required very much sophisticated and network, okay, that I have already talked about. Now this GFR is basically tightly regulated through several mechanisms, okay. So basically renal blood flow is relatively constant over a wide range of mean arterial pressure. So remember, when we plot basically your renal blood flow or GFR with the mean arterial pressure, so what happened, there is a range between 80 to 180, where initially what happened, initially there will be increase in renal basically your renal blood flow, then there is this region. So here with the change of MAP from 80 to 180, also there is no change in the renal blood flow GFR, okay. So then after this 180 there is slightly increase in there is again increase in renal blood flow, okay. So this is the major mechanism. So this is what the line want to say, that renal blood flow relatively constant over wide range of mean arterial pressure. So it will remain constant over wide range of mean arterial pressure, wide range 80 to 180, this renal blood flow will remain constant. So what is this basically this constant position is basically obtained by myogenic response, okay. This is obtained by myogenic response. Now you are entering into the pathophysiology or physiology of this, that is myogenic response. So what is myogenic response, okay, what the renin-angiotensin system, what are the role of renin-angiotensin system. So now you will enter into this two important domain, okay, two important domain. So what are these local responses? So whenever there is increase in the hydrostatic pressure in the afferent arterioles, so obviously you have afferent arterioles. So this is suppose, so this is Bowman's capsule. So here you have afferent arterioles and efferent arteriole. So whenever there is basically stress in this afferent arteriole, okay, whenever there is hydrostatic pressure increases in the afferent arteriole, what happens? They will stretch the vascular smooth muscle, and this stretching of vascular smooth muscle, what will do? It will open the ion channel, mostly the calcium ion channel. It will open the calcium ion channel. Now this calcium ion channel will result in depolarization and contraction of these muscles, okay, the renal artery muscle, okay, so in the renal artery muscles, and then they prevent pathological increase in renal blood flow that would damage the kidney. So this is basically in the normal conditions, okay, this is basically in case of normal conditions you can see such type of changes in case of your local responses. Now localized effect independent of autonomic regulation, as in case of autoregulation in other organ, falling blood pressure does the opposite, dilate the afferent. So this basically, this will reduce the pressure. When there is a reduction of the pressure, when the blood pressure has reduced significantly, what happens there? There will be dilation of the afferent arteriole. The afferent arteriole will undergo dilation, and basically that dilation will preserve the blood flow to the kidney. Next is renin-angiotensin system. So this renin-angiotensin system, this also act to preserve GFR. So basically you have juxtaglomerular cells. By now we know very well what are juxtaglomerular cells. So in the afferent arterioles, with release renin in the response to decreased stress. So whenever there is a decreased stress of the muscles, so what happens? There will be increased renin. Renin will increase, and circulating renin, this will activate what? Liver synthesize angiotensin 2 to angiotensin 1. Okay, liver will synthesize angiotensin 2, and this angiotensin 2 will be converted into angiotensin 1. Okay, then angiotensin converting enzyme ACE, which is coming from the lungs. Okay, angiotensin converting enzyme ACE, which is enzyme in the lungs. Okay, this is coming from the lungs. So now remember that angiotensin converting enzyme, it is present in lungs, remember, and basically angiotensinogen is present in liver. Okay, liver synthesized. So that is important, and is the vasoconstrictor. Okay, ACE is a vasoconstrictor. So now this image will tell you about the story. So suppose, so here you have macula densa. This macula densa, which basically will sense the low fluid and low sodium concentration, and obviously there are juxtaglomerular cells, and this juxtaglomerular cells, they will secrete renin. Okay, so renin, whenever renin are secreted into the blood, whenever renin are secretion in the blood, this renin will convert the angiotensin 1. Obviously they will convert angiotensin 2, so basically to angiotensin 1. So sorry, they will convert this renin with the help of angiotensinogen, they will form angiotensin 1. Now this angiotensin 1, what it will do? It will basically, with the help of angiotensin converting enzyme ACE converting enzyme, what it will convert this angiotensin 1 into angiotensin 2. So now this angiotensin 2 is basically responsible for widespread vasoconstriction. Okay, angiotensin 2 are stimulated for widespread vasoconstriction. Along with that, what it will do? It will affect on the adrenal cortex to secrete aldosterone. So it will also help adrenal cortex to secrete aldosterone, and hence when the aldosterones are secreted, what happens? This aldosterone stimulates sodium uptake on the apical cell membrane in the distal convoluting tubules and collecting duct. Okay, and hence this basically what happens? There will be release of ADH causes aquaporins to move to the collecting duct plasma membrane, which increase water reabsorption. Okay, so this is the basic mechanism of blood pressure maintenance by angiotensin 1 and angiotensin 2 ACE inhibitors and all. Okay, so remember angiotensin 2, they rise rapidly. Angiotensin 2 is basically vasoconstriction, and they will what do? They will stimulate the release of aldosterone, promote sodium retention, potassium secretion, and further increase in the blood pressure. So what they will do? They will retain the sodium, and they will increase potassium secretion. Okay, angiotensin 2 will increase potassium secretion. Okay, so basically you need to give potassium sparing drugs then. So now with this much of information, what we need to know? We need to know another very basic important thing, that is what is this tubuloglomerular feedback. So what is this tubuloglomerular feedback? So after knowing about myogenic responses, what you need to know is tubuloglomerular feedback. So now this tubuloglomerular feedback, so the role also again start with macula densa, which is basically in the thick ascending limb, sense an increase in GFR through increased delivery of electrolytes. Okay, they will sense increase in GFR whenever there is increased delivery of electrolytes. So increased flow, this leads to increased intracellular chloride concentration, which is sensed by sodium potassium chloride transport. So whenever there is flow will increase, obviously there will be increase in the chloride concentration. This will result in depolarizing the cell and leading to the release of ATP, adenosine and thromboxane. Okay, so paracrine mediators contrast nearby smooth muscle cell in afferent arteriole to reduce renal blood flow and thus return GFR to normal. Okay, so this is all about tubuloglomerular feedback. So macula densa, this can also independently stimulate juxtaglomerular cells to release renin and the activate RAAS. We have already talked about. We know this transport is implicated because effect can be attenuated by loop diuretics that blocks the sodium potassium channel, chloride channels. Okay, so renal autoregulation. Now remember, this point is very high yield. So renal autoregulation usually fails once the systolic blood pressure falls below 80 mmHg. So okay, after the systolic blood pressure is falling below 80 mmHg, your autoregulation will also be affected. Intrarenal biosynthesis of vasodilator, prostaglandins. Okay, there are biosynthesis like vasodilator, prostaglandins, in kallikrein and kinin are possibly nitric oxide also increase in response to low renal perfusions. Now, pathology. So what happened? Atherosclerosis, long-standing hypertension and old age can lead to hyalinosis and myointimal hyperplasia, causing structural narrowing of intrarenal arterioles and impaired capacity of renal arterial vasodilation. So you know very well that obviously there will be if there is in case of hypertension and all, what there is hyalinosis and myointimal hyperplasia all are occurring in case of arteriole, intrarenal arteriole. Okay, so that is again important. So and drugs, basically drugs are associated with NSAIDs. Okay, so these NSAIDs, they will inhibit the prostaglandin production and obviously hence they will limit the renal arterial vasodilation. Angiotensin ACE converting enzyme inhibitors and angiotensin receptor blockers limit renal efferent vasoconstriction, particularly pronounced in patients with bilateral renal artery stenosis or unilateral renal arterial stenosis. You need to know something about hepatorenal syndrome. So this can be type 1 and type 2. So type 1 acute kidney injury defined as greater than 2-fold increase in serum creatinine within 2 weeks without an alternate cause. Okay, and persistent despite for volume administration and withholding of diuretics. So basically you have in hepatorenal syndrome you have the type 1 hepatorenal syndrome. So in type 1 hepatorenal syndrome, what you will see, the acute kidney injury, it is defined when there is greater than 2-fold increase in serum creatinine, that is greater than 2.5 milligram per deciliter within 2 weeks without an alternate cause. Okay, so there is no alternate cause, but there is increase in basically your serum creatinine level and serum creatinine level without any increase in the alternate cause. There is persistent volume administration and withhold of the diuretics. And type 2 hepatorenal syndrome is less severe, from mainly characterized by refractory ascites. So now we come to the topic basis, that is acute tubular injury. So we have talked about different important aspects of tubules. Now we come towards acute tubular injury. Okay, so the most important the important topic of today's is all about acute tubular injury, so that you need to remember. So acute tubular injury, basically it is characterized by acute renal failure and often but not invariably morphological evidence. So remember, there will be renal failure, but remember, it's not necessary that necrosis is present. Okay, it's not necessary that necrosis is present. Without present of necrosis also, it is nowadays called as acute tubular injury. Okay, acute tubular injury. And they are the most important cause of acute tubular injury will be like prerenal, renal and postrenal. Okay, so this is this table from your Harrison, very important table, and basically it is explaining all the causes of prerenal. So prerenal, as we know very well, it is before the renal, before the blood arrives for the renal. So from where the blood is coming. Okay, so one, अगर वहाँ पे जाने वाला ब्लड का वॉल्यूम ही कम है तो हाइपोवॉल्यूमिया हो गया. और ब्लड क्यों कम आएगा? बिकॉज देर इज डिक्रीज कार्डियक आउटपुट हो गया. ओके, देर इज डिफेक्टिव इफेक्टिव सर्कुलेशन वॉल्यूम. ओके, लाइक कंजेस्टिव हार्ट फेलियर और लीवर फेलियर हो गया. एंड ऑब्वियसली देर कैन बी रीनल ऑटो रेगुलेशंस में प्रॉब्लम आ गए, जैसे कि NSAIDs, ACE इनिबिटर्स, ओके, और एंजियोटेंसिन रिसेप्टर इनिबिटर्स और साइक्लोस्पोरिन. डिफरेंट ड्रग इंड्यूस इंजुरी भी हो सकता है. Intrinsic we have already talked about. One is glomerular disease, all the glomerularitis. Another are tubules and interstitial disease, and other is vascular disease like vasculitis, malignant hypertension, and TTHUS. Okay, so now remember, in case of tubules and interstitial disease, what is important is basically it can be caused of tubular injury can be because of ischemia, it can be because of sepsis and infection, or it can be because of nephrotoxins. Okay, because of nephrotoxins. These are the important thing you need to remember about acute kidney injury. So we have talked about causes of these are the causes of intrinsic renal failure. So what are the causes of intrinsic renal failure? We have talked about that there can be associated with small vessels or glomeruli. It can be associated with large vessels. Okay, it can be associated with large vessels. Then it can be associated with different toxins, different drugs, okay, and different bacteria and viruses. So these all are the intrinsic renal failure or causes of intrinsic renal failure, which with a corresponding site where they will act. Okay, so you can just see this figure and try to memorize these things. Try to not mug up, but try to memorize this. So sepsis-associated AKI. So basically sepsis is a very important cause of acute kidney injury, which we have talked about. So basically sepsis, basically what does the sepsis does? So remember, आप सेप्सिस का पैथोफिजियोलॉजी जब पढ़ते हो ना, सेप्सिस का पैथोफिजियोलॉजी स्किप मत करो. व्हाई? बिकॉज व्हेन यू डू सेप्सिस का पैथोलॉजी जब आप पढ़ते हो तो व्हाट यू गेट इज बेसिकली यू कवर मोस्ट ऑफ योर जनरल पैथोलॉजी का जो चैप्टर इम्यूनोलॉजिकल चैप्टर है और जो इन्फ्लामेशन चैप्टर है, यू मोर और लेस कवर दैट चैप्टर कंप्लीटली. ओके, so where do you talk about acute kidney injury? What it does, it complicates more than 50% of cases of severe sepsis and greatly increase risks of death. So decrease in GFR with sepsis can occur even in the absence of overt hypertension. So it necessarily you don't need to be hypotensive disease in case of acute kidney injury. So now another important thing which you need to know is basically how this sepsis is causing AKI. So basically you have for sepsis to occur, it is the basically it is the pneumonia bacteria which are basically causing this sepsis. Okay, so the bacteria which can be associated can be like staphylococcus, streptococcus, E. coli, even fungi like candida. They all are associated with sepsis. Okay, they all are associated with sepsis. So what is this sepsis? आखिर sepsis है क्या? ठीक है, so sepsis है क्या? So basically when you talk about sepsis, see these are the gram negative bacteria. So this gram negative bacteria, या any kind of bacteria ले लो आप. So this is a bacteria. What happens? This bacteria, they will basically bacteria will secrete PAMPs, PAMPs. Now you go to your inflammation chapter and you will know PAMPs. Okay, DAMs. Okay, so basically pathogen associated molecular pattern or damage associated molecular patterns. So ये जो PAMPs और DAMs हैं, these PAMPs and DAMs, they will be recognized by your pathogen recognizing receptors, PRR. So pathogen recognizing receptors, and these pathogen recognizing receptors, what are these pathogen recognizing receptors? So PRR, pathogen recognizing receptors, are nothing but your different receptors which you get on the membrane, either on the membrane or intracytoplasmic. Okay, so we know very well in the membrane you are getting. So you again, this is your from chapter 2 is inflammation chapter. So basically I am trying to help you recall this. आप एक बार फिर से बैक जाके ये देख सकते हो कि there are toll like receptor which are basically which you can see in case of membranous. Okay, then you have cytosolic receptor like nod like receptors. Okay, nod like receptors. Then you have a rig like receptor which is also cytosolic and which is mostly for virus RNA. Then obviously you will have, then you have another type of extracellular, that is lectin is again an extracellular receptor. Lectin is again extracellular receptor. So what you need to know is basically you need to revise your thing that these receptors, that is pathogen recognizing receptors, that is node like receptors or toll like receptors, what they do, they recognize what happened, they recognize the pathogen associated molecules. Okay, that's for gram negative bacteria. This lipopolysaccharide is a PAMPs. This is a PAMP. So this is the PAMP. So pathogen associated molecules. Now this pathogen associated molecule, what they will do, they will basically bind to, or they will bind to different receptors like toll-like receptors. Okay, here the toll-like receptors, and these toll-like receptors, then whenever there will be binding, okay, then obviously there are different responses, cytokines and all, we know very well, we have talked in the second chapter. So these cytokines and all will secrete, okay, and then result into systemic inflammation. Now remember, what you need to remember is basically systemic inflammation is caused over here because of this gram-negative bacteria, or because of the PAMs and DAMs. Okay, PAMs and DAMs, they are causing systemic inflammation, and basically lastly finally causing acute kidney injury. Okay, so basically see here the sepsis, this sepsis, what they will do, they will activate these PAMs and DAMs, and what they will do, these PAMs and DAMs, basically they will bind to the pathogen receptor, basically pathogen recognizing receptors like toll-like receptors, nod-like receptors, rig-like receptors. Okay, and this binding will help, basically will whenever these DAMs and PAMs, they bind to pathogen receptors, so they will start a chain of reactions. Okay, they will start a chain of reaction, and that will result into AKI, acute kidney injury. Okay, so this is the important thing what you need to know about AKI, acute kidney injury. Now remember, is another type of injury as ischemia-associated injury. So before that, what I want to say is, I want to also add that, so what is sepsis? So you need to know sepsis. So this sepsis is nothing but sepsis is SIRS. So यहीं पे आप ये जान लो कि systemic inflammatory response syndrome plus infection is what you call it sepsis. Okay, so what is this sepsis? Is basically SIRS plus infection, it's called sepsis. Now what you need to know about SIRS is that is your body temperature. You say SIR when your body temperature is greater than 38 degrees Celsius or less than 36 degrees Celsius. Your heart rate, basically your heart rate is greater than basically 90 per minute. Your heart rate is greater than 90 per minute. Then you have basically hyperventilating, that is respiratory rate is greater than 20 beats per minute. Okay, and partial pressure of CO2 basically less than 32 mmHg. Then this temperature, heart rate, hyperventilation. Then you have basically WBC count. Okay, WBC count. So this WBC count are greater than 12,000 cells per liter, and in case of your or it can be less than 4,000 cells per liter. So this again, you see different things in SIRS. You see body temperature, you see heart rate, you see hyperventilation. Okay, you will see hyperventilation, and you see WBC count. Okay, WBC count. Or you can also have greater than 10% of immature neutrophils. Immature neutrophils should be greater than 10%, and that diagnosis will go in SIRS. So see, SIRS sepsis is nothing but it is SIRS plus infection. SIRS plus infection is what you call it sepsis. Okay, so that is again important thing which you need to know, remember in case when you are doing about this. And आप sepsis का pathophysiology पढ़ोगे तो basically that will help you to repeat or revise your chapter number 2 and basically your autoimmune disorders chapter. Okay, so both the chapter if you read basically that will help you and basically help you to revise that topic. Another type of kidney injury is ischemia-associated AKI. Okay, so we talked about kidney injury. So we did that there can be because of ischemia and all they can be causing, and this can be because of your DAMs and PAMs. So there another type of that is ischemia. So one is sepsis-associated AKI. So because of sepsis, okay, sepsis is causing ischemia. Then another is ischemia-associated AKI. So basically whenever there is ischemia, then that can also lead to AKI because obviously kidney medulla or they are more vulnerable to the ischemic damage. Okay, so basically the pathophysiology of ischemic damage is that whenever there is hypoxia, so whenever the hypoxia, so in case of hypoxia there you can see effect at two places, at the level of tubules and at the level of microvascular, that is at the level of glomerular, mainly medullary glomerular. So there will be vasoconstriction, there will be increase in the vasoconstriction whenever there is hypoxia. So there will be increase in the vasoconstriction, and basically this vasoconstriction is increased because of endothelin, adenosine, angiotensin 2, thromboxane A2, leukotrienes and sympathetic nerve activity. So we have already talked about these vasoconstrictive things, and this vasoconstriction There will be decrease in vasodilation in response to nitric oxide, prostaglandin E2 and acetylcholine and bradykinin. There will be increased endothelial and vascular smooth muscle structural damage, and obviously there will be result of leukocyte adhesion, endothelial adhesion, vascular abrasion, leukocyte activation and inflammation will occur. So this is about microvascular. In tubular, what happens? There will be cytoskeletal breakdown, there will be loss of polarity, apoptosis and necrosis, desquamation of variable cells and necrotic cells, tubular obstruction and backlash. You can see in case of ischemic acute renal failure. Then there is another type of acute renal failure, that is post-operative. So mostly the post-operative type of acute renal failure is associated with cardiac surgery. So cardiac surgery with cardiopulmonary bypass. So in this case, there is high chances of acute kidney injury when you are doing surgery. So vascular procedure with aortic, so then other type of example for post-operative AKI is basically your aortic cross clamping, and intraperitoneal procedures also can result into obviously acute injury caused by procedure. Now risk factor post-operative AKI. So the major risk factors are like CKD, older age, diabetes mellitus, congestive heart failure and emergency procedures. They are the major risk factor for post-operative AKI. Then burn and pancreatitis, they are also responsible for their, because their body fluid basically they come into the interstitial region and obviously causing edema and all. So what happen in case of burn, 25% of individual with greater than 10% of total body surface involved are they can result into burns and acute pancreatitis, which can result into AKI. So result in severe hypovolemia, resulting in decreased cardiac output and increase in neurohormonal activity. So what happens? This will result in dysregulated inflammation and increase risks of sepsis and acute lung injury will increase, and that will facilitate the development of progression to AKI. Okay, this will help to facilitate the development of AKI. So basically in this case what is happening, you are getting severe hypovolemia because burn and all acute pancreatitis. What they do, they shift the water from one place to another, okay, from intravascular to extravascular, and hence there will be hypovolemia. And whenever there is hypovolemia, this will result into decreased cardiac output, and obviously neurohormonal activation will increase. Okay, so basically this is and then that activation will result into dysregulatory inflammation and increased risk of sepsis and acute lung injury, which will facilitate the development and progression of AKI. Now massive fluid resuscitation for trauma, burn and acute pancreatitis develop abdominal compartment syndrome also. So this abdominal compartment syndrome, there will be increased intra-abdominal pressure, which is usually greater than 20 mm of Hg, and this will lead to renal vein compression and reduce GFR. Okay, so now this was about your ischemia-associated AKI. So we talked about firstly we talked about sepsis-associated AKI. Okay, then you talk about ischemia-associated AKI. Now we'll talk about nephrotoxin-associated AKI. So kidney basically it is very highly susceptible to nephrotoxic agents, and this is because extremely high output or high amount of blood which flows through the kidney. Okay, and because of that lot of toxic substance goes to the kidney, and basically some of them substance they are very highly toxic to kidney. Okay, so basically high concentration exposure of toxin to tubules, interstitium and endothelial cells will result into injury of these tubules, interstitial and endothelial cells. So one of the important agent which is responsible for nephrotoxin is contrast agents. Okay, contrast nephropathy, we also call contrast nephropathy. So this basically occurs because now contrast कब देते हैं, जब आप CT scan कर रहे हो. Okay, so like CT scan. So in the CT scan what you do, you use iodinated contrast. Okay, that is basically causing contrast nephropathy. In case of MRI what you do, you give high dose of gadolinium. Okay, gadolinium which is used for MRI, and also you give oral sodium. So oral sodium phosphate solution used as a bowel purgatives. Okay, then this contrast nephropathy, it can occur highly in case of CKD patient, that also particularly diabetic nephropathy. In case of patient with diabetic nephropathy, that is again very high yield point. Okay, this contrast nephropathy is high in case of diabetic nephropathy. Now again very high yield point, when do you say contrast nephropathy? So in contrast nephropathy, the serum creatinine, it begins to rise at 24 to 48 hours following exposure, and it will peak at 3 to 5 days, and about in 7 days this will resolve. So this basically ये डेट फैक्टर अपने आप में इम्पोर्टेंट हो गया कि सीरम क्रिएटिनिन पहले 1-2 दिन बढ़ता है, then your basically it will reach in the peak in 3 to 5 days, and then it will start resolving after 1 week. And you can see in contrast nephropathy, ये prerenal है, basically FENA will be low in this case. You need to remember factors causing this thing is like hypoxia in the renal outer medulla due to perturbation in the renal microcirculation and occlusion of small vessel. Then there will be cytotoxic damage to the tubules directly via generation of oxygen free radicals. So basically factors it cause hypoxemia can cause, oxygen free radicals can cause, okay, and then transient tubular obstruction can cause. So tubular obstruction can also cause this damage because of your in contrast nephropathy. So then next thing is antibiotics. So antibiotics, remember vancomycin, it can be associated with AKI, okay. So when it is associated with AKI, there will be basically particularly when trough levels are high and when used in combination with other nephrotic agent. Aminoglycosides and amphotericin B, they can also cause tubular necrosis. So amphotericin B or aminoglycosides, they can also cause your tubular necrosis. So basically aminoglycosides and amphotericin B, when we talk about aminoglycosides, so what happen in aminoglycosides, so the aminoglycosides, they are partially filtered by the kidney, okay. So I'll talk about aminoglycoside here. So aminoglycoside, what happened in this aminoglycoside, so they are basically partially filtered by the kidney. So basically filtered by kidney across the glomerulus. Okay, so they across the glomerulus they will be filtered by the kidney. Now what happen when they are filtered by the kidney? They will accumulate in the cortex. Okay, so this aminoglycoside, they will accumulate cortex, and hence this AKI will manifest after 5 to 7 days. AKI will manifest after 5 to 7 days, okay. So and remember, since this accumulates in the cortex, it can present even after stopping of the drug. So it can present even after stopping of the drug. Now this becomes a high yield point, okay. ये आपने आप में बहुत हाई yield point है कि AKI बेसिकली डिले दिखाएगा, एटलीस्ट इन 5 to 7 days में ही दिखेगा, एंड ऑब्वियसली देयर विल बी it can present, or this aminoglycoside can occur result into tubular injury even after the drug have been stopped because it accumulates in the cortex, okay. So remember hypomagnesemia, okay. So hypomagnesemia is basically the most common presentation of your this aminoglycosidic injury, okay. So it's the most common finding. Then you have another drug, amphotericin B. This is again amphotericin B. So this amphotericin B, what this will do? This will basically result into vasoconstriction, renal vasoconstriction, okay. So renal vasoconstriction, this renal vasoconstriction because of tubular feedback, tubuloglomerular feedbacks, okay, TGF. So tubuloglomerular feedback, and also because of directly tubular toxicity, there will be resulting in vasoconstriction, and hence this vasoconstriction will result into tubular damage. Now what happened? This amphotericin B is remember, it is a dose and duration dependent, okay. Dose and duration dependent. So longer you give, basically there are high chances of your amphotericin B will cause renal diseases, okay. So now this will present as polyuria, this also will present as hypomagnesemia. So it will also present as hypomagnesemia, it will also present as polyuria, and it will present as hypocalcemia, it will present as hypocalcemia, and also it will be presenting as non-gap metabolic acidosis, okay. Non-gap metabolic acidosis भी करेगा, okay. Now what happened? This amphotericin B, what will it will do? It basically binds to the transmembrane cholesterol. So it basically tubular membrane cholesterol binds to tubular membrane cholesterol. So ये क्या करेगा, ये ट्यूबुलर मेम्ब्रेन कोलेस्ट्रॉल को बाइंड करेगा, ट्यूबुलर मेम्ब्रेन कोलेस्ट्रॉल से बाइंड करेगा. सो दिस विल ट्यूबुलर मेम्ब्रेन कोलेस्ट्रॉल एंड हैंस दिस विल क्रिएट पोर्स. It will create pores in the tubular membrane and hence it will result into the injury. Okay, it will result into the injury. And so this was about the amphotericin B. Okay, so then another drug which is importantly you need to remember about acyclovir. Acyclovir. So basically this antivirus acyclovir, what happen, it precipitates, ये क्या करेगा, it precipitate in tubules. So ये ट्यूबल्स में प्रिसिपिटेट करता है एंड ऑब्वियसली दिस प्रिसिपिटेशन व्हाट इट विल डू, इट विल रिजल्ट इन ऑब्स्ट्रक्शन. ये प्रिसिपिटेशन क्या करेगा, अब ऑब्स्ट्रक्शन कर देगा ट्यूबल्स का. ओके, सो बेसिकली दिस ऑब्स्ट्रक्शन विल नाउ रिजल्ट इनटू ट्यूबुलर इंजरी. ये ऑब्स्ट्रक्शन हो जाएगा. ओके, एंड बेसिकली दिस विल बी सीन व्हेन यू आर गिवन इन केस ऑफ हाई अमाउंट इन हाई बोलस में देते हो, अराउंड मोर देन 500 मिलीग्राम पर मीटर स्क्वायर दे रहे हो. ठीक है, so this can be again acyclovir can also cause disease. Then another drugs like foscarnet, okay, foscarnet or pentamidine, tenofovir, pseudofovir. So these all drugs can also act with this formula only. Okay, then you have another group of drugs like penicillin, cephalosporin, okay, then quinolones or sulfonamides or rifampicin. So these all drugs are also responsible for AKI, but they are basically they will cause acute tubulointestinal diseases and then it will cause AKI. Okay, so toxic injections. Now coming to the toxic injections, so what you get this ethyl alcohol. So this ethyl alcohol which is present in the automobile antifreeze. So this is basically it metabolized to oxalic acid or glycoaldehyde and glycoxylate. This causes AKI, okay, through direct tubular injury and tubular obstruction. Then also you have diethyl glycol which is used as an industrial agent, and in this the metabolite 2-hydroxyethoxyacetate HEAA is thought to be responsible for tubular injury. Okay, so now again this is basically important, which of the agent is in ethyl alcohol and which of the agent in diethyl alcohol. So in diethyl alcohol it is HEAA. Okay, so HEA 2-hydroxyethoxyacetate, hydroxyethoxyacetate acid. Okay, so the acetic acid. So these are HEA, they are the agent which damage in diethylene glycol, and in ethylene glycol the oxalic acid, the glycoaldehyde and the glycoxylates are responsible for the damage. Okay, so this you need to remember in case of toxic injection. So ethylene alcohol, so the toxic injection ethylene alcohols are basically important. I just left out this chemotherapeutic agent I didn't talk about. So in chemotherapeutic agent you have cisplatin, okay, and carboplatin. So these are two important drugs which will be causing toxic. Now in cisplatin you need to remember cisplatin is dose limited toxicity. It will cause dose limited toxicity. And remember they also accumulate in the proximal tubule, so they do not precipitate but they accumulate in proximal tubular cells, and this accumulation will result into necrosis and apoptosis. Okay, so you basically you can see necrosis and apoptosis in case of cisplatin and carboplatin. Okay, so now there is also very high yield thing you need to know, that cisplatin that toxicity can be reduced by intensive when or mostly there is given the patient are given with intensive hydration. Patients are intensively hydrated, so this will reduce the toxicity of cisplatin. So intensive hydration will reduce the toxicity of cisplatin. That is another important topic thing you need to know for the examination point of view. Then there is another drug that is known as ifosfamide. So ifosfamide, So this drug basically will cause hemorrhagic cystitis. Very important, high yield hemorrhagic cystitis. Okay, or and also this can cause type 2 renal tubular acidosis, that is Fanconi syndrome. Okay, Fanconi syndrome. So these drugs can be responsible for this all. Then obviously there are bevacizumab, the zumab drugs. Okay, so this will cause thrombotic microangiopathy. Okay, thrombotic microangiopathy. So this about the and we have talked about toxic ingestion. Then another toxic ingestion is basically your melamine contamination of the food products through intratubular obstruction or possibly direct tubular toxicity. Then there is also another acid, that is aristocolic acid. Remember this aristocolic acid, this will cause Balkan's nephropathy. Okay, Balkan nephropathy. Now this is a very high yield question. Okay, Balkan nephropathy is caused by aristocolic acid, or it can also cause Chinese hub nephropathy. Okay, Chinese hub nephropathy. So this aristocolic acid can cause Chinese hub nephropathy or Balkan nephropathy, basically because of contamination of medical hub or farming, because of this aristocolic acid. So these are different. So in short, these are the drugs like antibiotics, mainly aminoglycoside, vancomycin, amphotericin B, antiviral like tenofovir, acyclovir, indivavir, chemotherapeutic agent like cisplatin, ifosfamide or carboplatin, NSAIDs, calcineurin inhibitors, cyclosporin and tacrolimus, inhibitors of mTORs like rapamycin and sirolimus, or angiotensin converting inhibitors, anesthetics like halothane, radiologic contrast agent, traditional hop preparation. So these drugs are responsible for toxicity in the kidney. Okay, then you have organic substance like ethyl glycol. Okay, ethylene glycol or carbon tetrachloride, heavy metals like mercury, lead, bismuth, urate. Okay, so these all are responsible for what happened, your injury, kidney injury, AKI. Okay, then there are some of the endogenous substances like rhabdomyolysis, hemolysis, transfusion reaction, myoglobin like cross injuries, statins and drugs, monoclonal immunoglobulin light chains, intratubular crystals like calcium oxalate and urates, and bile cast like with or without hepatorenal syndrome. So so this brings us to the very important table which of your your Harrison's. So this table is again of your Harrison's, and this table is importantly explaining so what is prerenal azotemia and what you should do in case of prerenal azotemia. So prerenal azotemia, we talked about main causes is your basically can be associated with cardiac output, or it can be associated with hypovolemia. So what you need to know, about that thing. So that if there is any fluid intake, poor fluid intake history, or there is vomiting, or there is anything sequestration into the extravascular spaces. Okay, associated heart failure, there are anything related to heart failure. So you need to see all those things in clinical feature. And prerenal azotemia, again we know very well that your bond to creatinine ratio will be above 20, FeNA will be less than 1%. You can see hyaline cast in urine sediment, urinary specific gravity will be immensely more than 1.018, and osmolality will again be, it will be hyperosmolar. Okay, so you remember that low FeNA, high specific gravity and osmolality may not be seen in the setting of CKD, diuretics use. And so if you have CKD, then you will not see these features, and hence you cannot diagnose as prerenal azotemia. If you are using diuretics, then also obviously these features will not be seen. Bone elevation out of proportion to creatinine may alternatively indicate upper GI bleed or increased catabolism also. So response to restoration of hemodynamic is must diagnostic. Then obviously we talk about sepsis-associated AKI. Okay, and remember, you don't need overt hypotension for the diagnosis of AKI always. Okay, overt hypotension only not, in other conditions also sepsis-associated AKI can occur. Mainly what you do, so you do positive culture, you try to diagnose the sepsis, causative agent of sepsis, the gram negative, gram positive bacteria. You see urine sedimentation, often which contains granular cast and renal tubular epithelial cast. FeNA, which may be less than 1%, particularly early in the course, but usually greater than 1% with osmolality less than 500 milliosmolality per kg. Then you have another ischemia-associated AKI. Okay, we have talked about ischemia-associated AKI also. Then you have other causes like nephrotic associated endogenous factors like rhabdomyolysis, which will be because of cross injuries, traumatic cross injuries, seizures, immobilizations. What it will be here in rhabdomyolysis? Obviously there will be myoglobin will be high, and creatinine kinase will be high, urine hem positive with few red cells, FeNA visually less than 1%. Then another obviously endolysis causes is hemolysis, basically RBC. They can also cause this nephrotoxic, they can be also nephrotoxic. Then there is tumor lysis syndrome, that is if then recent chemotherapy is given, and in this you see remember tumor lysis syndrome, hypermarked, there will be marked hyperphosphatemia with hypokalemia. So you will be given history of hyperphosphatemia and hypokalemia, then you should think one of the finding will be your tumor lysis syndrome. Okay, always remember one of the finding can be tumor lysis syndrome in case of hyperphosphatemia and hypokalemia. So ये आपको याद रखना है हमेशा के लिए. Okay, that is important point you need to remember in case of hyperphosphatemia and hypokalemia. Okay, so this is tumor lysis syndrome. Even in rhabdomyolysis also you will see hyperphosphatemia and hypokalemia. In multiple myeloma basically you can see obviously monoclonal spike in urine and serum and electrophoresis. And now remember this point is important, low anion gap. Okay, mostly in case of renal disease you are seeing high anion gap, but in case of this multiple myeloma the anion gap will be low. So this is again a high yield point which you need to remember in case of multiple myeloma. Okay, multiple myeloma में anion gap low हो जाएगा. That is again a very high thing, important thing which you need to know in case of this disease. Okay, then we have talked about contrast nephropathy. Okay, contrast nephropathy, we talked about some other causes like tubular injuries, interstitial nephritis. Okay, interstitial nephritis, that is again important, high yield point you need to know. Then some other causes of like glomerulonephritis, we have talked about all glomerulonephritis in our previous classes. Interstitial nephritis, okay, we have talked about interstitial nephritis. So this interstitial nephritis, they can also cause basically intrinsic AKI. Then you have TTP HUS. Okay, TTP HUS also again very high yield point. Remember here what you see is neurological abnormality and or AKI, recent diarrhea illness, use of calcineurin inhibitors, pregnancy or postpartum and pregnancy or postpartum or spontaneous. So these are basically clinical features you get in TTP HUS. Peripherally what you will see cystocytes on peripheral blood smear, you will see elevated LDH, you can see thrombocytopenia. Okay, you can see thrombocytopenia. So basically you remember HUS is basically associated with diarrhea. So in HUS, when you do investigation for HUS, what you do, you measure SIGA toxins. That's why you measure SIGA toxins which are released from E. coli. Okay, you measure SIGA toxins which are released from E. coli. That is important in case of HUS. Okay, typical HUS. There are two types of HUS. One is typical HUS, one will be atypical HUS. So remember, atypical HUS is basically, it is genetics, basically hereditary. Okay, or basically when you know about atypical HUS, there is dysfunction is in the complement dysregulation. Okay, there is probably associated with complement dysregulation. Okay, now when you talk about HUS and TTP, so what you do to do another important investigation against SIGA toxin, you also do Adams TS13. Okay, so this is Adams TS13. Basically what this Adams TS13 is nothing but it is basically it is a protease, von Willebrand factor, WVF factor, or protease of von Willebrand factor protease. Okay, protease protein. So this will basically help to cut VWF factor, and hence this is also an important investigation which you do in case of this your TTP and HUS. Okay, then another there is other cause of your tubular injury, intrinsic AKI, is atheroembolic disease. Okay, so this atheroembolic disease is again very important thing you need to know. This is basically recent main clinical presentation is recent manipulation of aorta or other large vessel, may occur spontaneously or after anticoagulation. Retinal plaques, palpable purpura, and libido reticularis and GI bleed are the most common symptoms which you see in atheroembolic diseases. Okay, now what are the most important finding is hypocomplementemia, eosinophiluria, variable amount of proteinuria will be seen in case of atheroembolic disease. So very important you need to remember is eosinophilia can be seen. Then you have post-renal AKI. Okay, post-renal AKI basically associated with obstruction and all, and in that major investigation will be your basically what you need to do is imaging, radiological imaging you need to do. Okay, so now this brings us with the this table of your Harrison's, that is prerenal azotemia and oligouric acute renal failure. Okay, so what do you say in prerenal azotemia? Prerenal azotemia is basically before the renal, or it is above the renal. It's not associated with the renal. That is, your tubules are basically normal. Your tubules are basically normal, and the problem is above the renal things. That is, problem may be because of sepsis, maybe because it is can be associated with hypovolemia, it can be associated with cardiac problem. Okay, so in that case the osmolarity of the urine will be very high because tubules are functioning normally. So urine osmolarity is basically greater than 500 milliliter. Okay, and remember, the urine osmolarity or tubules are working very properly, so they will absorb sodium also properly. Hence there will be the sodium fractional excretion of sodium will be less than 1%. Okay, less than 1%. Now remember, urine creatinine and plasma creatinine in this case will be obviously greater than 40, because urine creatinine will be high than the plasma creatinine. Okay, because the problem with there is no problem with your tubules. Okay, so the urine creatinine basically will properly, it will be filtered, it will go filtered without any obstruction and all. Okay, then in case of urinary cast, normally here is hyaline or granular cast, but in renal case there will be muddy brown. Okay, and urine plasma creatinine, and this is less than 20%. Remember, fraction excretion of sodium will now be more because tubular, there is problem with the tubules over here. Okay, and since there is problem over the tubules, the osmolarity will be again less than 350, that is again very high. Then urine sodium is basically is less than 20 in this case, but urinary sodium will be more than 40 in this case. Okay, 1 is to plasma creatinine ratio greater than 20. This is 10 to 15 is to 1. So this again basically your 1 is to plasma creatinine ratio is greater than 20 is to 1. So this is about how you differentiate between prerenal azotemia and oligouric acute renal failure. Okay, so what are the laboratory tests you do in acute kidney injury? So basically you get muddy brown cast. Okay, and obviously sludged epithelial cells in urine. This is in case of intrinsic. Okay, this is in case of intrinsic renal failure. Then you can see the markers also, like Kim, Nagel, interleukin 18, or in the blood you can see Nagel or cysteine C. So these are these different markers which you can see, or they are the markers for injury of the kidney. Okay, so in urine what you can see, in urine you can see cast. Okay, different types of cast. So remember, whenever there is urine sedimentation in AKI, if there is if it can be normal or few RBC or WBC or hyaline cast. Okay, so in that case it can be either normal or it can be any of this prerenal, postrenal, or any embolism or HUS, TTP or scleroderma crisis. But if there is abnormal in sediment, if you see RBCs and RBC cast, then that is that goes more towards your glomerulonephritis, vasculitis, malignant hypertension, or thrombotic and microangiopathies. If there are more or WBC cast, then there it can be interstitial nephritis, glomerulonephritis, pyelonephritis, allograft rejection, or malignant infiltration of the kidney. If there are renal tubular cast cells, okay, pigmented cast, then it can be acute tubular necrosis, tubulointerstitial nephritis, acute cellular allograft rejections, and myoglobinuria and hemoglobinuria. If the cast are granular, obviously there will be acute tubular nephrosis, glomerulonephritis, vasculitis, and tubulointerstitial nephritis. Eosinophiluria, very much important thing you need to know is atheroembolic disease. So eosinophiluria, atheroembolic disease. Others are like allergic interstitial nephritis, you will know by yourself, by the name itself. Pyelonephritis, cystitis, and glomerulonephritis, very less, but importantly you need to know atheroembolic diseases. Okay, and crystalluria, again crystalluria, what you need to know is calcium oxalate, that is ethylene alcohol intoxication, so ethylene glycol intoxication. Basically this is because of oxalic acid, so calcium oxalate will be high in this case. Okay, acute uric acid nephropathy, and different types of drug like acyclovir, sulfadiazine, amoxicillin, and indinavir, they can also cause crystalluria. But importantly, this ethylene glycol endogenous toxic nephrotoxic agent are important. And you have different noble biomarkers. Remember, BON and creatinine, they represent functional biomarker, okay, of glomerular filtration. they are not the biomarker of injury but they are functional biomarker. ठीक है, that is an important, and basically they are, hence they are suboptimal for the diagnosis of actual parenchymal kidney damage. So remember, in case of oliguric AKI or intrinsic kidney injury, urinary flow rate in response to bolus intravenous, you give bolus intravenous furosemide around 1 to 1.5 milligram per kg, and this can be used as a prognostic test. How? Whenever there is urine output of less than 200 ml over 2 hours after invasion of furosemide, then it may identify patient at a high risk of progression to more severe AKI, okay, and need for renal replacement therapy. So this is for furosemide, bolus intravenous furosemide is have a prognostic value that you need to remember for your examination point of view. Another thing you need to remember about examination point of view is that more the tubular epithelial cells or granular cast in the urine, the sediment, the kidney disease associated will be more severe, or there will be worsening of AKI. That is again very high important thing. So the noble marker, the first noble marker is kidney injury molecule 1 or KIM1, okay. So this KIM1 is basically it detected shortly after ischemic or nephrotoxic injury in the urine. In normal condition they are not expressed, okay, they are not expressed in the absence of tubular injury or extrarenal tissues, and they are basically type 1 transmembrane protein which are abundantly found in proximal tubular cells, which can be found only in case when there is ischemia or nephrotoxic such as cisplatin, okay. So the main function of this KIM1 is basically what? It confers the phagocytic property tubular cells, enabling them to clear debris from the tubular lumen after kidney injury, and basically they also reduce the inflammatory response to acute injury. Now another important thing which you need to is neutrophil gelatinase associated or lipocalin, NGAL. So this is the NGAL, also known as lipocalin 2 or siderocalin. So this was the first protein which is discovered as protein in granules of human neutrophils, okay. They can bind to iron sidero-4 complex and may have tissue protective effect in the proximal tubule. So they are highly upregulated after inflammation and kidney injury and can be detected in the plasma and urine within 2 hours of cardiopulmonary biopsy associated AKI. So this is very important and most important cause of post surgery AKI, that is cardiopulmonary bypass, okay. Then another very important biomarker is basically combination of insulin like growth factor binding protein 7 and tissue inhibitor of metalloproteinases, okay, TIM2, tissue inhibitor metalloproteinase, and insulin IGF factor B7, okay. So they are basically predictive biomarkers for higher risks of development of moderate to severe AKI in critically ill patient, okay. So in critically ill patient, which of the biomarker is important? TIM2, okay. Your options would be TIM2. They can give you NUGGL, KIM1, BUN and TIM2. So TIM2 is most important one, okay. TIM2 is important, you need to remember. So with this much of information, I think we should conclude today's class. So basically you try to integrate things from your physiology, okay, integrate things from your physiology and your Harrison's. जाके एक बार आप Harrison's पढ़ो. Basically most of the things are from your Harrison's only. Go read your Harrison's once, okay. So if you read your Harrison's one, so you will basically understand the topic matter. You will understand the topic matter more properly. Basically sepsis का pathophysiology पढ़ो. Sepsis का pathophysiology will help you to revise your general pathology completely. So आपका जनरल पैथोलॉजी लगभग completely रिवाइज करने में हेल्प कर देगा योर सेप्सिस का पैथोफिजियोलॉजी, बिकॉज दिस सेप्सिस का पैथोफिजियोलॉजी आपका टोल लाइक रिसेप्टर्स को ले लेगा, पैम्स एंड ऑल को ले लेगा, है ना, एंड देन ऑब्वियसली डिफरेंट साइटोकाइंस का रिलीज, कैसे डिफरेंट साइटोकाइंस रिलीज हो रहे हैं, एंड बेसिकली डिफरेंट देन हाउ दिस साइटोकाइंस विल एक्टिवेट द इम्यून सेल्स, इम्यूनिटी सेल्स को कैसे एक्टिवेट कर देंगे. So with that all you will basically you will understand it in a better way. So I'd like to thank you all for bearing me this long, and remember you can subscribe to our channel, YouTube channel. Basically you can subscribe to YouTube channel. You can also contact us with the Telegram channel, and you can hit the bell icon for notification of different classes, and you can use my code Anil Live, okay. So basically what I say, integrate करो आपका जो physiology पढ़ा रही हैं मैम, okay. So basically you see Horror lectures also side by side. So tubules का functions and all. Then know about the Fanconi syndromes. Okay, Gitelman syndrome के बारे में अभी जान लो, Fanconi syndrome के बारे में जान लो. So basically आप सब कुछ ये tubular injury के बारे में जान लोगे. तो now that becomes very easy for you to understand which drugs, why do it injure, कौन सा drugs कहाँ पे इफेक्ट कर रहा है, नेफ्रोटॉक्सिन्स के बारे में समझना, एटियोलॉजिकल फैक्टर समझना और फिर पैथोफिजियोलॉजी समझना बहुत इजी हो जाता है इफ़ यू नो फिजियोलॉजिकल कंडीशंस वेरी वेल. ओके, सो बेसिकली इस टॉपिक को आपको इंटीग्रेट करना ही करना है. ओके, थैंक यू वेरी मच. सी यू अगेन इन टुमारोज क्लास. हैव अ ग्रेट डे. गुड नाइट.